Hello guys, today we will talk with you about hip dislocation, and it's more interesting topic than last one. Okay, hip dislocation often happened with trauma. For example, it is 3 or 7% of the all dislocations, and it's happened more often with men, and it's, I think, because men's more often do any sport and physical activity, but not yet. Of course, women have some another structure and anatomy of this joint, and for women, it's harder to have a hip dislocation. Now we will talk about mechanism of trauma. When we talk about hip dislocation, it is a result of indirect mechanism when the physical impact applied to the femur exceeds the functional capabilities of the hip joint. Yeah, and there you can see any types of this trauma, what can lead to the hip dislocations. What you need to know more. Depending on the direction of force, the femoral head may dislocate posteriorly or anteriorly from the acetabulum. And it is really non-interesting important. It is really important because sometimes these any types of the dislocations will give another clinic. We delayed dislocations of hip for 4 main types of dislocations. Posterior upper iliac hip dislocation, posterior with a single hip dislocation, posterior static hip dislocation, anterior supralateral hip dislocation. The not supralateral, there is supralunaris, I think. We will talk about this. It is a problem with translate in English. We haven't got this word. Okay, and the last one, anterior locking hip dislocation. You need remembering that iliac dislocation of the hip is more often observed. It is 85% than sciatic locking, and in the last place, supramental dislocation of the hip. Supramental. Yeah. Okay. Clinical pictures. A characteristic mechanism, of course, patient will say you that he, for example, be in car accident, followed by severe pain and loss of hip joint functions. Active movements in the hip joint are impossible, and when a patient trying to perform passive movements, we have a symptom of spring resistance. The lower limb is deformed and occupies a forced position, characteristic of each dislocation. Iliac dislocation. Look, there you see in right side a picture where we have all types of these 4 dislocations, and when we talk about iliac dislocation, look, first of all, I will tell you what we have. The hip is moderately bent, broad, and rotated inside. Yeah, and there you see this picture. Small rotated inside and moderately bent. A decrease in the functional length of the limb is noted. A large speed is defined above the Rother-Nelaton line. In the gluteal region, on the dislocation side, the femoral head can be palpated in their side. Okay, there is iliac dislocation. We will go forward to next type, sciatic dislocation. When we talk about sciatic dislocation, the hip is significantly bent, broad, and some rotated inward inside. Okay, the head of the femur is probe down and posteriorly from the acetabulum. Okay, the next one, it is a supralunar dislocation. The limb is unbent, somewhat withdrawn, and rotated outwards. There you see it. During palpation, the femoral head is determined under the inguinal ligament. There. Okay, lock and dislocation. When we talk about lock and dislocation, we see that the limb was sharply bent at the hip and knee joints, and have rotation outward, outside. What more? And we can find large speed in the area of the locking hole. Oh no, we can find a large speed on the area of the locking hole. Yeah, sorry. And please try to remember that when we talk about anterior dislocation, we always will have a cyanotic color of the limb, because we have compression of the arteries. Yeah, you see that arteries go away from the domain in anterior side of leg, and if the caput will go to anterior side, yes, anterior dislocations, it will compress to the arteries. Okay, and there you see some X-rays films, and there you see that caput go down, but there we see normal physiological anatomy, and there the same situation, caput go away. In normal situation we see this normal space of intra-joint, space intra-joint, yeah, sorry. Treatment, and there is very interesting for you, I think so. Hip dislocation is an injury in which it's immediate elimination and it is necessary. General anesthesia is used, and only if it is impossible to perform general anesthesia, we can use a local anesthesia. The joint is injected 30-40 milliliters of 1% of procaine solution, complementing the analgesic effect with an injection of 1-2 milliliters of another type of painkillers. Ways to eliminate dislocation. We have two types of reduction. Type of method of Dr. Coherent and method of Dr. Genelidze. And I will tell you some interesting moments of these methods. The method of Genelidze, what we do: patient placed on the table face down so that the damaged limb hangs from the table. Yeah, you see he lays there and leg go down. This is the first page, this is the second page. From the table, and in this position he lay 50-20 minutes. Then the injured leg is bent at the hip and knee joints at an angle on 90 degrees and slightly withdrawn down. Yeah? The surgeon captures the distal part of the lower leg and presses on the patient's lower leg with his knee. Traction is performed along the hip axis and then several main rotational movements. Yeah, he pull down, yeah, and do any rotation movements. It's very necessary. And the hip reduction occurs with a characteristic click. The same, maybe some another click. Confirmation of the achieved goal is considered to be the absence of a symptom of spring resistance and a control radiographic examination. The Genelidze method. There you see a big picture. What about the Coherent method? The Coherent method is often used to eliminate anterior hip dislocations or stale dislocations, regardless of the type. The patient is laid down on the floor. The assistant fixes the pelvis with two hands. The surgeon moves the patient's limb at a right angle in the knee and hip joints and produces a slowly increasing extension along the hip axis for 5-10 minutes. This manipulation can be facilitated by the technique described by Keffer. Yeah, I will show you first of all how we do it. Yeah? And now we will talk about Keffer method. The surgeon kneels and bends the other leg at a right angle and brings it into popliteal fossa of the patient. Grabbing the shin with his hand in the lower third, the doctor presses on it posteriorly and as a level pulls the high. After traction, the hips are broad and then they rotate outward his leg. With each type of dislocation, the stage of segment reduction should be the reverse of the mechanism of its occurrence. It is very important to remember. In conventions with laying the patient on the floor when using the Coherent method, Keffer method can be avoided by using the following techniques. It's not normal that patient lay down on the floor, and we can use, for example, dressing table, bandage table, at the level of the damaged hip joint with his back to the bed. Patient lay down on the bed. He places a dislocated limb with the popliteal fossa on upper arm. Surgeon stay back to patient. Patient is there, and he take his leg on the shoulder. Yes, and do like in Keffer method, but Keffer used knee, and this method we use shoulder of doctor. And further forward we do like in Coherent method. Now we will talk about immobilization of the hip. After the hip is set, the limb is immobilized with a through-shaped spar from the angle of the shoulder blade to the ends of the fingers for 2 weeks. Yeah, and there you can see some types of this immobilization. Really, I never see this type of immobilization, and we always use another technique, and now I will show you it. Plaster immobilization can be replaced by cuff disciplinary traction with a load weighting, for example 1-2 kilograms, for the same period. Yeah, and you see that there we have another mechanism. There we see special mechanism what push leg on this vector, yeah, because there we have some kilograms, some weighting, and leg go forward. What about rehabilitation? We can use UHF, procaine electrophoresis. After the immobilization is eliminated, walking on crutches is prescribed for 8-10 weeks. The load on the damaged limb due to the danger of developing aseptic necrosis of the femoral head is allowed no early than 3 months from the moment of injury. Recovery of working capacity occurs after 14-15 weeks. Okay guys, that's enough. Thank you very much, and in next topic we will talk about lower limb. Okay, thank you very much, bye bye.